Hi guys, I'm back with the last cytopathology video as I had promised. I am extremely sorry for the delay in uploading the videos since I have not been keeping well, and but hopefully soon the problem will be resolved and I'll be able to upload more frequently. Since today is Teachers Day, so I wish all of you a very happy Teachers Day, and I'm going to be finishing cytopathology today, and then we'll start as soon as I can recover. We'll start with histopath, and I've got some hematology lectures pre-prepared, so I'll keep uploading them. I might not be able to upload them frequently because of my health, but I'll at least try to upload once every 15 days, and once I recover fully, then I can then go back to uploading more frequently. This would be a little long. There are 18 slides to it because I want to take this topic in a bit detail, because this is important both in practical scenario as well as clinically. You will get a slide of fluid cytology because there are some very important questions which are asked on this topic. I read the fluid cytology part when I was doing my MD from Grace. I find Grace to be very comprehensive. I am not discussing PAP because I've already discussed PAP in all types of specimens. So I'm not discussing that. I'm just going to be taking this lecture from the viewpoint of what you are asked in your exams, rather than dealing with the entire spectrum. Also, do study the entire topic of Gray for this particular topic, the entire book, made this chapter. Please go ahead and study from Grace. There is this part of fluid cytology mentioned in Grace where they have shown like a technique similar to microarray, where excuse me, multiple fluids can be examined in one go. There's a method of doing that. That is a very late new, that was a new technique when I gave my MD exams. Higher centers use that kind of a microarray technique to put molecular etc. But you have to know that how it is graded, how those samples are set in one uh, page, I mean one smear, how those cell blocks are made, and how they are used. Please do that, and how they are read and how they are used in IHC. That those 3-4 pages are very important. Apart from that, I've already taken in PAP. You will be asked about the maturation index, etc. All that is given in Grace. So it's not given in other books, but it is given in Grace in a comprehensive manner. Please go ahead and read the topic after listening to me, because there are so many things that Grace will tell you theoretically. I am just going to be discussing the practical viewpoints and the viva questions that you're going to be asked. Okay. Before I start, let me give you a very quick overview of what kind of fluids you get in the pathology department. Either you get a CSF for TLC, TLC to rule out meningitis or Guillain-Barré, etc. Or you get fluids like pleural fluid from the pleural cavity over here. You get pericardial fluid when there's pericardial effusion from the pericardial cavity. This is the pericardium, and the space between the two, let me change to a pen actually, and the space between the two layers is when gets expanded with fluid, then it is called pericardial effusion. You might get it from the abdominal cavity. This is the thorax. Okay. um, these are the ribs over here if you see. So parietal peritoneum you will get from the pleural fluid, okay, from the pleural cavity as shown over here. You can get ascitic fluid from the abdominal cavity where peritoneum is there. Okay, you can get from the joints, that is synovial fluid. Again in Grace, a separate topic is given for synovial fluid. You should know when synovial tapping is done, how to identify rhagocytes. RHAGOCYTES. What are rhagocytes? All these things are asked if you get, and how do you grossly identify that the fluid is synovial fluid? Okay, and you might get abscesses from liver, etc. So most importantly, clinically, when we get a fluid grossly, when we see it, we examine it. I'm going to take it further on कि color कैसा है, transparency कैसी है, coagulum है कि नहीं, blood है कि नहीं, volume क्या है. This is what, these are the headings. Grossly, we examine the fluid, and what the clinician wants to know is whether it is transudative or exudative. So I found this chart on net, and I really like this thing. Everything in excess is an exudate. So XX. Exudate will be mainly infective fluid. When there's TB, when there's some pneumonia, some sort of infection leading to effusion, then that will be an exudative fluid where all the values will be raised. And transudative is when there's renal failure, when there's congestive heart failure. So बैक प्रेशर से जो नॉर्मल फ्लूइड कलेक्ट होने लगता है जब ड्रेनेज प्रॉपर नहीं हो रहा होता, दैट इज ट्रांसुडेटिव फ्लूइड. ओके, the next chart will define the difference more clearly. So transudative fluids, transudate मतलब I remember it जैसे membrane के through transudation हो रहा है, ठीक है. And exudation again, X is for excess, so infection में सब कुछ बढ़ जाता है, so that is exudative. So now definition, transudative is filtrate of blood plasma without any changes in endothelial permeability, क्योंकि कोई इन्फेक्शन नहीं है, कोई इन्फ्लेमेशन नहीं है, आपका पंप खराब है या आपका इफ आई से यू से बड़ी लेमैन टर्म्स में योर सीवेज टैंक इज नॉट वर्किंग, दैट इज ईदर योर किडनीज आर नॉट वर्किंग or your pump, that is your heart is not working, so there's a lot of back pressure. The fluid is fine, but नालियों में, that is your vessels में, there's a lot of fluid accumulated which is causing back pressure. और उस बैक प्रेशर की वजह से जब नालियां भर जाती है तो पानी कहाँ आता है, रोड पे आता है. तो ये क्या जा रहा है, ये जो कैविटीज अवेलेबल होती हैं ऑर्गन के लाइनिंग में, उसको भर के एक्सपैंड कर दे रहा है, ठीक है. एक्सुडेटिव इज व्हेन एंडोथीलियम की परमेबिलिटी इफेक्ट हो रही है, इन्फ्लेमेशन हो रहा है, बैक्टीरिया आ रही है, टॉक्सिन्स आ रहे हैं, वहाँ एंडोथीलियल डैमेज हो रहा है, उससे फ्लूइड बाहर निकल गया. So transudative is non-inflammatory, it is inflammatory. Grossly, it is always clear to palish yellowish. This will be turbid or cloudy. ठीक है. Why it becomes turbid? Because everything is raised, protein is raised, glucose might be glucose will be probably be low, because again bacteria needs glucose for energy, तो glucose कम होगी, but protein is raised, cells हैं, blood है उसमें, ठीक है, that is why it is cloudy. प्रोटीन लो और नो टेंडेंसी टू कोएगुलेट इसमें हाई होगा. इसमें प्लाज्मा से ग्लूकोज से क्योंकि कुछ है नहीं ना, बस इसमें जो फ्लूइड आगे निकल जाना चाहिए था, यूरिन से बाहर फिल्ट्रेट होकर निकल जाना चाहिए था, वो सब रुका हुआ है, दैट्स इट. एक्सुडेट में क्या है, कोई इन्फेक्शन हो रहा है इसलिए ये प्रॉब्लम हो रही है, सो दैट इज द रीजन व्हाई इट हैज अ हायर प्रोटीन कंटेंट. नाउ बैक्टीरिया टू वर्क नीड्स ग्लूकोज, सो इट हैज अ लोअर ग्लूकोज कंटेंट. Transudate, the glucose will be normal. Specific gravity, of course, less than 7 and more than 7. LDH will be high in exudative. In fact, I think this thing, specific gravity should be more in exudative. So I think this is some error. Then I'm going to talk about Light's criteria and tell you what it is, how to differentiate. Matlab, if you can calculate the Light's criteria, then you can say the fluid is exudative. Okay. And then there's something called the SAG index. I'm going to tell you about that ahead, further on in the lecture. And then of course the transudates will have few inflammatory cells just because of stasis, and mesothelial cells. इसमें खूब सारा inflammation होगा exudate में, and there may be mesothelial cells. So I have already taken that exudative fluids are due to infections, etc., malignancies, and जो hydrostatic होते हैं, जो back pressure से होते हैं, they are transudative. Okay. This is Light's criteria. So if pleural fluid protein by serum protein, मतलब आपने pleural fluid का protein calculate किया and blood का ratio is greater than 0.5, और pleural fluid LDH and serum LDH ratio is greater than 0.6, ठीक है, then this is an exudative effusion. And the point rider over here is that pleural fluid LDH greater than 2/3 of the upper limits of norm is normally normal होता है pleural fluid का 2/3 से serum LDH का. लेकिन अगर फिर भी ये रेशियो अगर आप निकालो एंड ये 0.6 से ज़्यादा जा रहा है, ठीक है, then this is an exudative fluid. Of course, glucose will be low where there's bacterial infection. It can be amylase, suppose in pancreatitis है, esophagus में कुछ है, perforation है, sepsis है जिसकी वजह से हो रहा है. pH can be low in rheumatoid, it more acidic, it will be more towards acidic. Fine, ammonia can be there. Creatinine, we don't test all of these things. Glucose we do, protein we do. Bile we can test if it is greenish in appearing, and then we perform cell blocks into IHC and molecular investigation. ठीक है, we can do an ADA is always done to rule out TB. Fine, CRP can be done. TSA, these markers can be done. Lipids, I'll show you what a chylous fluid is and then tell you. Okay. So SAG I told you about is serum to if there's ascites then जो serum में albumin है and जो ascitic fluid में albumin है उसका gradient निकालते हैं, ठीक है, that is serum albumin minus the ascitic fluid albumin, and if the gradient is greater than 1.1 the cause is alcoholic or portal hypertension, ठीक है, और CHF or cirrhosis, some sort of a long-standing chronic cause. And if the gradient is less than 1.1, then it is either nephrotic syndrome or carcinoma or something else. Basically, SAG is done to see that the portal hypertension and the ascites which is happening is due to a primarily liver cause or something else. It is not, it has got nothing to do with transudative or exudative. वो Light's criteria था. SAG is done to see whether the ascites is due to liver or not. And liver का cause can be cirrhosis, alcoholism, portal hypertension, कुछ भी. So if it is more than 1.1, it is due to liver. If it is less than 1.1, the gradient, then it is due to some other thing than liver, like kidney or pancreas. Okay. So microscopically, I told you we mentioned the quantity, color, appearance, whether there's a clot or coagulum, because TB is quite common to have a coagulum, and turbidity hai. Then we see what kind of super. So if that a fluid is turbid, we centrifuge at 1500 RPM for 10 minutes is what I do. Fine. And then we see जो supernatant है, अगर clear है तो ये मान के चलो all the elements were dense, heavy cells and they settle down. However, it is still hazy. So supposing you centrifuge this, something was completely hazy, alright, something like this. It was completely hazy. Now आपने इसको centrifuge किया, so यहाँ पे आ गए आपके sediments, which I am going to be making with this color. So these are your sediments, okay? ये sediments आ गए, और ये जो पूरा fluid है, again change the color, ये पूरा क्लियर है, तब तो मान के चलिए ये सेलुलर एलिमेंट्स हैं एंड देन दीज आर सेल्स एंड मे बी एक्सुडेटिव. Supposing this is still hazy, so I'm going to be making this with yellow. Supposing, and I'll take a broader pen. Supposing this is still hazy. So what is this? So this could be, this is called chylous fluid. This could be chyle. Chyle is when lymphatics are blocked. Then the lymphatic fluid cannot be carried and drained. ठीक है, and then that starts leaking out into the blood, into the surrounding spaces and the peritoneum, etc., and gives a milky color to the fluid because lymphatic fluid is whitish in color. So we have to now so that happens in blockage of any lymphatic or thoracic duct, ठीक है, फाइलेरियासिस में बड़ा कॉमन हो सकता है वो, एंड या ट्यूमर है जो ब्लॉक कर रहा है, सो दैट इज वन कॉज. व्हाट इज pseudo-chylous? You even after centrifuging you'll get a hazy appearance of the supernatant. However, that is not actual chyle, that is due to something else, and that something else is if there is TB, if there is myxedema due to thyroid, if there is rheumatoid arthritis, pleuritis. In those cases also this kind of a hazy picture comes even after centrifuging. So chylous fluid is always sudden in onset, okay, milky white to yellow, and this will be gradual. Pseudo-chylous से TB है तो वो ग्रेजुअल प्रोसेस होगा, और सडन ब्लॉकेज ऑफ लिम्फेटिक में ही chylous fluid आ जाएगा. इतना लंबा लिम्फेटिक ब्लॉकेज की there won't be time for you to wait for the lymphatic blockage to present as a chylous fluid. Tuberculosis will take months to appear, so the fluid of TB will be gradual. Fine, it can be milky to greenish to metallic sheen. This will be milky white to yellowish. Of course, pseudo-chylous effusion, you will have a mixed cellular infiltration can be there because of multiple reasons. Chylous, just this is lymph fluid. So what does lymph have? Lymphocytes, so lymphocytosis. Triglycerides will be high in chylous fluid, and chylous means chylomicrons, means triglycerides and lipids are high in this fluid, fine, as compared to a pseudo-chylous fluid. Then how do you calculate a TLC TLC of a fluid? So a fluid is sent to us practically for TLC TLC and or cytology. So TLC TLC we do on Newborn's chamber, and then we have dilution factors where by using this formula you can calculate if you're using WBC lyse Turk's fluid, then we do it into 5. If you're using RBC, into 50. Normally we do it with WBC fluid. We all know that. We take the fluid, we add Turks, we leave it for 10 minutes, then we charge a Newborn's chamber, we count, and we do into 5. Then the fluid might be turbid, and then you need to make dilutions, and then you use this formula. N is here over here n into the dilution factor जो आपने बनाया है upon the total area, ये तो constant रहने वाला है आपके न्यूबॉस चेम्बर का, and you calculate. This is physiology was done in the first year of your MBBS. So आजकल क्या होता है ना, हमारा n is number of cells, हमारा fixed रहता है बाकी calculation, so we just multiply by that number. So however, if you change the dilutions of the fluid that you've gotten, then you have to again use this formula to recalculate. So in peritoneal fluid, a WBC count more than 250 and neutrophils greater than 50 is definite bacterial peritonitis. If you see a pleural fluid more than 10,000 is inflammation. Pneumonia is more than 50,000. TBVB may you can say less than 5,000 cells and approximately less than 1,000 cells in transudative. You'll ask me why less than 1,000 in transudative, why are we seeing 1,000? Because stasis हो रही है. तो जो जिस फ्लूइड की स्टैसिस हो रही है, जो आपका बाहर आ रहा है वेसल से, वो था तो ब्लड का ही फ्लूइड ना, तो कुछ सेल्स भी बाहर आ जाते हैं, बट दैट डजंट मीन इन्फेक्शन. तो वी सी कि 10,000 से ज़्यादा है तब इन्फेक्शन बोलते हैं, 10,000 से कम है देन वी आर लाइक. और अगर खूब लिम्फोसाइट्स हैं 5-6,000 देन वी गिव अ कॉशन फॉर टीबी एंड वी गो फॉर एन एडीए इन द फ्लूइड इटसेल्फ. ओके, देन कमिंग टू दी हिस्टोलॉजी, जब हमें साइटोलॉजी के लिए मिलता है तो व्हाट इज मोस्ट इम्पॉर्टेंट व्हेन वी आर असेसिंग अ फ्लूइड इज, आपको ये पता होना चाहिए कि जब फ्लूइड में कौन सा सेल नॉर्मल है कौन सा नहीं. Transudative and exudative are mainly dealing with inflammatory cells. So yes, one thing you get is inflammation. Supposing a malignancy is suspected, always remember that the mesothelium has a lining. So this is mesothelium. Fine, here you can see this section has this cleft-like space of the mesothelium and a lot of fibrosis and hemorrhage, and it has this kind of a flattened lining, and these are stromal cells. Sometimes due to inflammation, such plump cells can be seen, but this is not malignancy, this is reactive atypia. Something like this which was flat has become like this. Okay, so this is atypia. Even this kind of a hobnailing is atypia. Okay, this is focal or diffuse reactive hypertrophy. Now these cells, when they come out in the fluid, they come as sheets and clusters. So here you can see a honeycomb kind of a sheet. If you see like there's spaces in between, you see this, but this is a tight cell ball. Fine, and you can see a prominent nucleoli also. But this is benign because these are very uniform. See, the nuclear chromatin is so uniform. The sheets are honeycomb-like with space in between. Fine, this kind of a knobby kind of thing is there. Okay, and but the chromatin is very homogeneous. Similarly, a honeycomb, a nice honeycomb pattern with the borders of the membrane very clear seen over here. Or you might see these kind of frayings in the border of individual cell of the cytoplasm. So all this is benign. Okay, and this is what you need to know, that when you get a honeycomb pattern, or even when there are clusters of cells, mesothelial cells, but they are not 3D clusters or tight clusters, the borders are not very knobby or bobby, the cluster has some honeycombing and spaces in between. इसको कहते हैं mesothelial windows. This is known as mesothelial windows. So this is there, honeycomb pattern is there. Even if there is some nuclear ATP, I'll show you the ahead. But ये मिल रहा है ना, then this is benign or reactive rather than calling it malignancy. Fine. Now you see this has a lot of fluid. ये इसने खूब सारा pinocytosis कर लिया है. Fine. And some cells around are dying. Then again you see a lot of windows are present. And even if with all these nucleoli, you are getting these windows, then this cluster is benign. Here you see vacuolated macrophages. They must have these mesothelial cells eat up a lot of fluid when they are floating, and they look like and they become these laden macrophages. This is a reactive mesothelial cell, probably would look like something like this. Okay, look at the NC ratio over here. These are macrophages again, जिन्होंने pinocytosis किया हुआ है. Okay, even on the basis of the type of information that you get with mesothelial cells, you can make a diagnosis. So if you get this kind of a cell where there's something eaten up and the nucleus is pushed to one side, this is a neutrophil actually, then you can diagnose a Lee cell and you can make a diagnosis of SLE, because SLE very commonly involves the lungs. Okay, if you're getting eosinophilia more than 10%, see how many differentials you have: parasite, drugs, then pneumothorax, trauma, infection, heart failure. There's so many different differentials. So these are eosinophils that you're getting with other cells in the population. Okay, then you might get cholesterol crystals, these kind of calcifying bodies. Fine. Then you might get starch granules. See this eaten up over here. Fine. This is something eaten up over here. And see, all this is reactive. This is not malignancy. This is not Hodgkin's. Now you need to understand that a very uniform cell border with even a very dangerous looking nucleus does not mean it is malignancy, because mesothelial cells have a tendency to mimic carcinomas when they are reactive, and this will confuse a young pathologist. So even I used to get confused, so I always keep that dictate that when you are analyzing a fluid and you get these cells, no problem, you are not able to discern ki ye kya hai, because when you study Grays, they are going to tell you that, see, a mesothelial has this clear area around the nucleus, it can be binucleate, the cytoplasm may have these frizzy borders. I look for a cluster always. ठीक है, all that said and done, I'm giving you a practical tip. I look for a cluster and then I look for mesothelial window. And if I am getting few clusters with mesothelial windows, I am going to presume this is reactive. But also mention in my report, correlate radiologically and follow up. ठीक है? So, or you get a lot of inflammation and no other cell. I'll show you malignancy also after this. Now you see. Now you see over here, if I show you this field, a lot of reactive cells over here. ठीक है, ये बाइन्यू I don't know where my marker has gone now. हाँ, let me just change the color, I can't see it. So you see a binucleate cell over here, something eaten over here. ठीक है, then these atypical looking, then also I honestly will not be able to tell you 100%, but this cell I will find, okay, this could be a suspicious cell. Then what I'll look for, okay, I'll go ahead and I'm looking at another space, say this cell. Yes, cell you can see in a reactive population also, but why is the nucleus pushed at one end? Means there is something inside which is pushing. So what is this which is inside? Is it normal fluid? Normal pinocytosis I showed you, itna compressed nucleus nahi hota, so this could be mucin. And if I'm doubting mucin somewhere, then I have to think of adenocarcinoma. Then I look for these clusters. You see, there are no proper windows over here. Okay, there are no windows in this cluster. So then my doubt increases that this could be carcinoma, adenocarcinoma, mesothelial I don't know. So I use this panel then. So calretinine and WT1 will always come positive in mesothelioma. Rest all TTF, MOG, BARIPI and all this, you go for adenoma. Okay? So this is what I do. So yeah, that's it. This is a long lecture. Basically, I wanted to tell you the difference between reactive and benign mesothelial cells. One question. Second, and difference between transudate and exudate will be your second question. Third question will be the maturation indices and PAP. Fourth, the IHC between mesotheliomas and adenocarcinomas. Then, what are the various type of reactive mesothelial cells you can see? Of course, I've already told you how you will differentiate. They might ask you in recent advances the latest techniques applied on fluid. You should know cell block, immunocytochemistry, all right, and from Grace, do read that topic on microarray kind of a application of cell blocks using fluid cytology. So that is all you get in fluid. It is short, crisp, concise, but very very important. You are going to get a question on fluid. It can't be that you won't get it. Okay, so please, after listening to me, I have just sensitized you to fluid. Please read that fluid chapter from Grace, and then you can get back to me with any queries. Also, please support my book Manual of Hematology. It is available under my name. The name of the book is Manual of Hematology on the website of Ahuja Brothers. So please support me, and I'll be able to post my next video on hemat after some time, because I'll be undergoing some treatments now. So please take care till then, and please keep supporting me. Hopefully after 15 days I'll be posting a new video now. So till then, please tell me how you like this video. Please share with your friends, and please support my book and my channel. Thank you.